Bag for about a second. Watch the chest wall, make sure it's moving up and down properly. Listen for leaks, 10 to 12 breaths per minute. Synchronize with the patient's effort if they're somewhat awake so that they're comfortable, and 100% oxygen. And always make sure that the oxygen is hooked up. You want to have some cricoid pressure on the patient so they don't aspirate. So what you want to do is you want to put enough pressure that it will compress the esophagus. If you look at things anatomically, you look at CAT scans and everything, you can see the relationship between the trachea and the esophagus. Trachea is a relatively rigid structure, the esophagus is soft, so you take this rigid structure, press it down, and it compresses the esophagus. The other important part of that is that there's less air that will get into the patient's stomach, which will also predispose to aspiration. And you'll see that when these patients come back from being resuscitated, they're all blown up. They have a bunch of air in their stomach. Patients that are on CPAP will aspirate a ton of air as well. So downward pressure on the anterior neck includes the esophagus, and it also may help with visualization of the cords during intubation. You really can't see this. It doesn't come out very well. Okay? Difficult airway, bottom line is call for assistance. It says it somewhere on that slide, I swear. So what we talked about is manual mask ventilation is difficult or impossible in only 5% of the population. And what are the things that are going to tell you that that's going to be a problem? Presence of a beard, no teeth because there's collapsibility of the mouth, obstructive sleep apnea, BMI greater than 26, believe it or not, which is like, that's like almost everybody that we see, right? 26 around here is a supermodel, actually. And age greater than 55 years. And then intubation by direct laryngoscopy is difficult in approximately 5% of the population and impossible in 0.2 to 0.5%. Those are the ones you don't want in your emergency room. So this is the Mallampati classification, and it gives you some, idea as to what the task at hand is going to be. The anesthesiologists love this, and allows them to grade the patients in addition to grading them from a health perspective. So class 1, you can sort of see everything. Class 2, you can't really see the base of the uvula, but you can still see the back of the airway and the uvula. Class 3, the back of the airway is gone with a tiny bit of the uvula, and class 4, it's like all bets are off, right? And these are the people that you're going to have trouble with. And even though you guys don't always like to have anesthesia around, this is the time where you want anesthesia around. And you want somebody around that's a skilled operator. You want somebody around that may be able to do fiber optic bronchoscopy, or you want to look at the glide scope. I don't know where our glide scope is. It's missing. It must be sitting in someone's room.
We got it, yeah.
What's that?
We have all the parts now.
Okay. And you really want to have your accessory equipment around, and you maybe you want to have something around to do an emergency tracheostomy. Now that situation happened yesterday in interventional radiology.
Almost happened.
Very close.
Yeah.
And it happens every once in a while. And the more you unsuccessfully try and intubate these patients, the higher the probability that that's going to happen, because as you try to intubate them, you will end up with trauma, airway swelling, and an airway that wasn't very good to begin with is going to get worse and worse. And so sometimes you have to know when to not do things is just as important as knowing when to do things. And you sort of learn that with experience, that sometimes doing nothing is really doing something. So you have these alternative airways. Now we don't have the tracheal, the esophageal tracheal double lumen devices, but what they have is they have a proximal balloon and a distal balloon. Okay, and the distal balloon goes into the esophagus. The proximal balloon occludes up here, and then you can ventilate the patient through that. In the LMA sort of just sits in the pharynx, and here's an LMA. And in some of these LMAs, you can pass tubes through them. And actually, you could probably, if you could get an LMA and know it's in place, This is called a bougie, and these bougies will pass into the airway, then you can pull that and you can put the endotracheal tube in over the bougie. When we have people with who've had difficult airways and we're going to extubate them, we'll check for air leaks and so forth. But every once in a while, we'll throw this through, pull the tube, and if the patient has a problem, then you can just re-intubate them over the bougie. And some of these bougies allow for ventilation, actually. Some of them have attachments that you can actually hook up to oxygen if you want to look at these things. And we've had a few, patients in here that have ended up with LMAs. And then they've been successfully reintubated. So what are the indications for endotracheal intubation? So, airway protection, which we talked about. If you're not awake and alert and can clear your secretions, it doesn't matter if you're oxygenating well at the time, because unless you have something that's acutely reversible, like a narcotic overdose that you're going to get better from, or something that's changing your mental status that's going to go away pretty quickly, you want to protect the airway. If you have obstruction for any reason, you want to, maintain an airway. If you want to provide mechanical ventilation, if you have respiratory failure, shock, CNS injury, increased work of breathing, difficulty clearing secretions, these are all indications to intubate a patient. And so again, it comes down to airway assessment. You want to pre-oxygenate people if you can. So if you know they're going to have to be intubated, but you can maintain them with a mask, you want to get their O2 sats as high as you can. And who are the people that are going to be the ones that are going to deoxygenate the most quickly? If you're going to pick two groups of people.
Kids and kids.
Kids to a certain degree, and then in the adult population, obese, and who else? Pregnant women. Pregnant women. Because pregnant women have a reduced functional residual capacity because of the diaphragm being displaced upwards. And the same thing with obese people have a decreased functional residual capacity, if you remember your pulmonary physiology. That's the combination of your expiratory reserve volume and your residual volume. So they drop their sats very, very quickly. They will drop like that. And it's especially important in pregnant women because you're not only dealing with the pregnant woman, but you're dealing with the fetus as well. So you want them as pre-oxygenated as they can possibly be. If you have an OG or NG in, that's great because you can decompress the stomach. It reduces the risk of aspiration. And you want to give appropriate analgesia, sedation, amnesia, neuromuscular blockade is indicated. If you have somebody that's completely out of it post-code and they're not responding, they don't need anything. And I would prefer that be done because then you can assess to see if they're going to wake up and decide on further therapies. But, somebody that's somewhat awake and struggling, you want to look at these other modalities. And you want to decide what the best modality is for that particular patient. You want to see what their neck mobility is like. Do they have a history of arthritis? Do they have a history of a prior cervical neck injury? People that have a history of arthritis, it's the atlanto-occipital junction that can be unstable, and if you snap their head in the wrong way, they can be paralyzed. So those are people that you may want to consider like a cervical spine injury. Facial structure, people that have micronathia, or recede, their jaws are somewhat receded, are much more difficult patients. They tend to airway obstruction. I once had this guy that had micronathia. He was the skinniest little guy, and he had severe sleep apnea because he just occluded his airway very easily because of the micronathia. And I could tell you he would have been a difficult patient to intubate. If the mouth opening is less than 3 fingers, it's an indication you may have a problem. You want to look at the tongue and pharynx. Every once in a while you see these people with macroglossia or people that come in with angioedema present a particular problem because their tongues just fill their oral cavity unbelievably. And you want to measure the jaw distance between the thyroid cartilage and the chin, and if less than 3 fingers, that's an indicator that their cords may be anterior. And anterior patients are very difficult to visualize. Options for difficult airways. They'll tell you about these people that come in with, airway edema or epiglottitis. You can do an awake, sitting intubation, right? Nasopharyngeal. And you can do that over a scope, actually. And it's very easy to intubate over a scope when you're doing it through the nose, if you can pass everything. You may get stuck at the choanal at times, but if you can get everything through, it's a very good thing, because you have a nice, it's a rigid structure for your scope to go through. You can get down to the cords and then just throw the tube over the scope. Fiber optic intubation. When I was in training, we used to do some burn unit, and what we would do is we would evaluate airways for airway edema. And if we had people that were intubated, as we were extubating them, we would put the scope through the endotracheal tube. We would pull the tube back very slowly to the point where we're just right above the cord, so we can continue visualization. If they still had airway edema, you could slide the tube back in. Because the scope was through, you could throw the scope through the course because it's so small. Awake tracheostomy is a brutal thing that's happened here a couple of times. You can use the LMA, needle cric, surgical cricothyrotomy, and you guys have cric trays in the ER, right? Mm-hmm. And then percutaneous trach, which almost happened yesterday. But in order to do a percutaneous trach and have a successful outcome, you need to be oxygenating the patient as well. So you may want to do the needle cric prior, at least, and oxygenate them. You can stick a 16 gauge catheter into an airway too and throw oxygen in. And one of the things they do with jet ventilation, I don't know, jet ventilators, they go from a rate of about 80 to 120 breaths per minute, small puffs of air. They use them for airway surgery, and you can hook them up to a 16 gauge cannula that you pop through the cric. And you'll ventilate and oxygenate fairly well.
In a pinch, how could you deliver oxygen, like in a code, say, or something? You didn't have that ventilator.
I guess you could just hook it up to the IV, really. I'm sure you could somehow pop in a catheter and somehow attach that to an oxygen source. Just cut off the nasal cannula and screw it onto the end of the IV catheter if you really had to.
I heard you could use a 3 milliliter syringe and cut right, and actually the ventilator could fit over there.
Yeah, if
Oh,
you take
okay.
the plunger part off
Yeah.
of it, yeah.
Yeah, I guess you could. I didn't even think about that. But yeah, you can. But there's a lot of ways that you can attach things to oxygen sources. You'd be surprised. One of the things that we do sometimes is when we change endotracheal tubes, I throw a suction catheter through the tube I'm pulling, and then I put in the other tube over the suction catheter, but you can throw those things in and you can attach them to oxygen. You can attach OG tubes to oxygen sources. There's all kinds of things you can do. So when you want to intubate somebody, how do you want to, what do you want to give them? Topical anesthetics are a great thing to prep them if they're somewhat awake. These are just the different drugs that we use. Fentanyl, you can use, it's rapid onset, short acting, but when you give large doses, you can actually get what's called like a rigid chest syndrome. That's transient but occurs, and then the patient just cannot move their chest. Midazolam is rapid onset and short acting because of significant respiratory depression. So the other thing you have to understand is that when you're going to intubate somebody, you better establish in your head whether you think it's going to be easy or hard. Because if you think it's going to be hard, you don't want to knock them out too much. Because once they're like knocked out and paralyzed and you can't get an airway, then you're really like deep in it, right? So you want to take that into consideration. When midazolam first came out, I was in training, and it was advocated that you would give 2.5 milligram IV to put patient under moderate sedation. So we used to do our bronchoscopies by ourselves with a respiratory therapist. At Hahnemann, we had a bronch chair. At Crozier, we had converted a closet into a little bronch suite, actually. And there was a small chair in there with the patient. You were surrounded by all the equipment. When we first started using midazolam, and everybody respiratory arrested because it was too big of a dose. So we're like in this closet intubating this patient over a bronchoscope, waiting for the midazolam to wear off. So there's a black box warning now, so you start low and you build up. And one of the cardinal rules when you're using respiratory depressants or things that are going to change the level of consciousness or things that are going to cause hemodynamic effects is always start low. You can always give more, but you can't take out what you gave. And it's a very important lesson to learn. And you will learn it sometime in your life after you give too much of a medication and have an adverse effect. And you go, oh my God. And you're just going to stand there waiting for it to wear off and hope it wears off before anything bad happens. Now you can sort of save yourself from midazolam now with romazicon. And you can reverse the narcotics, with Narcan. Which is another good thing about those types of drugs, the morphines, the fentanyls, the benzos that are relatively short-acting. Romazicon was sort of made for midazolam, and it was really made for, these conscious sedation situations where the patient was just oversedated. Etomidate provides sedation. It's good for head injury patients, no cardiovascular effects. You don't want to have too many cardiovascular effects when you're intubating someone with a head injury. But it can cause myoclonus, and it's notorious for adrenal suppression, especially in septic patients. And then lidocaine given intravenously will blunt the response to intubation, and it may reduce elevations of ICP during intubation. So I know you're taught during RSI courses that if you have a head injury, lidocaine is a good drug to give along with whatever else you're given. Neuromuscular blockers, okay, succinylcholine. Is a great drug because it's rapid onset, it's of short duration, so if you paralyze somebody and you can't intubate them, and somebody that you were able to bag, it's going to wear off in a relatively short period of time. The contraindications are people with crush injuries, burn injuries, certain types of muscular problems because they'll get hyperkalemia. And so if you have a patient that codes after you give them succinylcholine, think about hyperkalemia. And think about reversing hyperkalemia. And it can also cause malignant hyperthermia. I've seen that a couple of times. And then vecuronium, rocuronium, and cisatracurium are your non-depolarizing agents, so people won't fasciculate. But they're longer durations of action. So if you have a difficult intubation and you've given that drug, you're stuck with it for a long time. So you have to be wary about what you're doing. The thing with succinylcholine, because of the fasciculations, they'll get elevations in intracranial pressure. That was one of my, succinylcholine was on my boards, and etomidate was on my boards too, specifically for those two reasons. Etomidate for adrenal suppression and succinylcholine for its contraindication to elevated intracranial pressures. So those are really important things to do. Those are questions at the last. And it's nice to know the answer without having to think too much. So, and rapid sequence intubation is really simultaneous administration of sedatives and neuromuscular blocker. So you put the patient down and out essentially, and that way you have less resistance to the intubation. Like I say, like when I bronch people with head injuries, I usually paralyze them first so they don't cough. And they won't get elevations in intracranial pressures, and it's a nice thing. Of course, that's while they're intubated. I don't paralyze the ones that aren't intubated. And it's a technique of choice when there's an increased risk of aspiration, and the airway appears not to be difficult. That's the key to it. I mean, you really have to learn to evaluate the airway so you know when you're going to be in trouble and when you're not going to be in trouble. And you will get fooled some of the time. Whenever you tell somebody that this is going to be an easy procedure, it always turns out to be difficult. So always tell them this is going to be the most difficult procedure I ever did, and then it usually turns out to be quite easy. So I think that's about it. So that's just a quick overview. I hope that's helpful. And that's it. Any questions or anything? All right, thank you guys. So what's next?